Anthony Bafaboni, and today I will be having a nice conversation with Dr. Maria Cirino Macano about antibiotics in outpatient setting for COPD exacerbation. Dr. Macano is an assistant professor of medicine in the Department of Pulmonary and Critical Care Medicine. She is also the director of the Advanced COPD Clinic at Carilion Clinic. Thank you and welcome, Dr. Macano.
Thank you, Dr. Bafaboni.
Very good. So I'll call you Maria. I wanted to start off with what's your favorite movie?
So I'm a kid at heart, and it might not be very interesting to other people, but it is Tangled from Disney.
Tangled. So yeah. You must sing a lot. That's good. The next time we will have some singing as well. Thank you for sharing that. That's a little tidbit to know about Dr. Macano. So going forward, we're going to be talking about COPD. And Maria, tell me, how do we define COPD? The primary care provider, I'm seeing a patient, usually who would be my person who has COPD and therefore, have an exacerbation of COPD. What does it look like?
So COPD is a condition that happens after certain exposures, although there are some people that are predisposed to it depending on comorbidities, like, for example, HIV patients. But in COPD, there's systemic inflammation that affects the airways and the lung parenchyma, causing problems with the filtering of oxygen through the lungs.
Excellent. Thank you so much for that nice explanations. So the next question I had is, a patient with COPD, known COPD, comes to you with shortness of breath. How do you know whether you're dealing with pneumonia and they happen to have COPD, or this is simply an acute exacerbation of their COPD? Because it's very likely what you do with them may be different.
Yeah, what we do with them is different, actually. But you have to think that a pneumonia, the patient's a little bit more toxic. The symptoms are a bit more severe. Those patients may present with fever. They have more sputum production. They're more short of breath than the patient with exacerbation of COPD. And they may have an increased white count. A pneumonia is more systemic inflammation, whereas an exacerbation of COPD is more local, it's more bronchial. And it is important to recognize which one's which, because usually an exacerbation of COPD, the most common cause is a viral infection versus a bacterial infection with a pneumonia. So in those patients, I do a chest x-ray and I look for an infiltrate, and that will let me know if it is truly a pneumonia or an exacerbation of COPD, which will have a negative chest x-ray.
Excellent. Oh, that's very good to know. Very, very good to know. And my next would be, I think you kind of mentioned this briefly, is with acute exacerbation of COPD, which seems to be the more commoner thing. The causes are myriad. What are some of the causes for acute exacerbation of COPD?
So the most common cause is actually an infection, but most infections are going to be viral, and they are caused by rhinovirus being the most common virus, followed by respiratory syncytial virus, influenza, human pneumometavirus. So there are different viruses that can cause this. Bacteria might be present, but it is less common than a viral infection. So the most common cause of bacterial exacerbation is Haemophilus influenza, followed by Streptococcus and Moraxella. But we have to also remember that not all exacerbations of COPD are because of an infection. About 30% of exacerbations can be due to an exposure. For example, when there is high pollution, those times when the levels of ozone are very high, there has been data showing that there are increased rates of exacerbation, and also when patients are exposed to pollen and other things. So not all exacerbations are infectious.
That's very good to know. It looks like bacteria form a lesser, portion of the cause for acute exacerbation of COPD, and some of the causes cannot or will not be treated with antibiotics. Viruses can be a big um, instigator, or sort of be a big cause for an acute exacerbation. When does a patient, um, have, if there is alarm, when should the patient alarm the provider or let the provider know maybe something has changed? I feel different. What should the patient look out for? Since we know that sometimes people can start off with a viral infection and then it can progress to something else. How would you, as a primary care person, advise your patient and make them feel as well heard in terms of their symptoms?
So, as I said, an exacerbation of COPD means inflammation, which might be because of an infection or not. So whenever a patient tells me that they have increase in their symptoms, being shortness of breath, cough, sputum production, the first thing that I ask is, what color is the sputum? What does it look like? If they have purulent sputum, yellow or green, that is not their baseline. That is when I consider antibiotics. If it is clear, or if it is a dry cough, antibiotics are really not going to help the patient, but we still have to decrease that inflammation, and that is when we give steroids. So we can give steroids without the antibiotic, but the most important thing is the purulence of the sputum.
Okay. That's very good to know. And so you're really acting on the history that you capture from the patient. And do you tell sometimes your patient, hey, if things change, what do they do?
Yes, absolutely. Because, we live in this culture where we think, well, my doctor is not giving me antibiotics, so he or she's not doing anything for me. And that's not the case. I feel that, and it has been my experience, that when I explain to patients, this is why I'm not giving you antibiotics. You have clear sputum production, so this is mostly viral. So antibiotics are really not going to help you right now. But if your sputum turns yellow or green, give me a call and I will prescribe an antibiotic. That is when it is indicated. And patients actually will do that. They will be fine if I don't give them anything, and they will be in contact with me if they see that the purulence of the sputum is present now.
That is it seems very reasonable and actually a good stewardship strategy that you have described. Thank you for doing that. So I think this slide that we have up buttresses exactly what you have said. Is there any other specific nugget within this you may want to highlight?
Yes, absolutely, because we have to think, for example, about immunocompromised patients, that they may not have purulent sputum because they cannot mount that, immune reaction. So those patients, I would have a lower threshold of giving antibiotics. Also, patients that already have a history of colonization. For example, patients that have bronchiectasis and are colonized with Pseudomonas or staph. And definitely patients admitted to the hospital that have severe symptoms, those patients that need ventilatory support, that they need the ICU. One of the things that is being promoted at this time in the pulmonary community is actually the use of biomarkers. CRP, for example, has been shown to be elevated in patients, both in and outpatient, that have exacerbations of COPD, and they can actually guide our antibiotic treatment. And the important thing is that using CRP, using biomarkers, we're able to decrease the rate of antibiotic prescription without increasing the rates of hospitalization, rates of pneumonia, death. There is no difference in patients' quality of life and no need for further antibiotics.
Okay. So, Maria, for a primary care provider, how do you envisage that they could operationalize the use of biomarker in their practice? So one, I hear about making sure you taking that good history to sort of differentiate and give you a good idea of what's going on, viral versus not, inflammatory versus something else, pneumonia. And then there is ability to use biomarkers as you describe here. In your practice, when you do order a biomarker, how quickly do you get it come back? And then I presume when it comes back, you are able to, along with everything you've taken in terms of your history of the patient, able to reach out back to the patient to give some advice. How does it work in your practice?
Well, in most places, most labs will have a CRP level result the same day. So there's not a lot of wait for the patient. But unfortunately, that is not everyone's practice. So if I do not have a lab where I can have the results of a CRP level, within the next, few hours or maybe the next day in the morning, then I just go with the purulence and sputum. What is your baseline sputum? Or is it yellow or green when it used not to be, or you used to not have sputum at all? And that is what guides my antibiotic treatment, if it needs to be done, or if I can just give an anti-inflammatory such as a steroid without having to give an antibiotic.
Thank you so much, Maria. This has been a wonderful discussion. In generality, it does look like in patients with COPD, taking that good history is extremely important to help sort of get a sense of where they are in terms of whether this is all viral inflammation or inflammation versus something else. And then giving the patient some information about if it turns, something changes from their baseline, making sure that they are able to reach out is another thing. So that way we save the appropriate antibiotic for the patient when they have their true infection or true sort of bacterial condition. We are able to treat them appropriately. Thank
Absolutely.
you so much. Are there any other things you want to say before we call it a wrap?
Yes, just one last thing, and is that this is really important to give antibiotics when appropriate, because COPD patients are prone to infections and there are very high rates of resistance, and we want to prevent that. So to give the antibiotic when it's needed versus other treatment when the antibiotic is not indicated is key.
Thank you so much. I really appreciate you doing this. Thank you.
Thank you very much.